السلام عليكم. هنبدأ مع بعض فعاليات المؤتمر عشان نبدأ بس on time. أنا هتكلم على السيزاريان سكشن عندنا في مصر. يمكن احنا كلنا عارفين احنا من الدول اللي بتعمل سيزاريان سكشنز كتيرة زيادة عن اللازم. Why do we have a very high rate in Egypt? أول حاجة more rewarding to the doctors. مع الأسف الدكاترة بتاخد فلوس أكتر في السيزاريان، مع إن في دول أوروبا الدكاترة بتاخد فلوس أكتر في الفاجينال ديليفري. Less labor intense، بتاخد مجهود أقل كتير قوي. Fear of litigation لأسباب ما نعرفهاش. القضاء بيعتبر إن السيزاريان سكشن is safer. لو الدكتور عمل سيزاريان سكشن وحصل مشاكل ما بيحصلش اي حاجه قوي، لكن الفاجينال فيها كده. misinformation ان في there is information out there that cesarean section is better for the patient, which is false, and there's lack of will to correct the problem. البوليسي ميكرز عندنا مش بيحاولوا يصلحوا المشكله. زي ما انتم شايفين مصر اللون بتاعها we have a very high rate of cesarean زينا زي تشاينا، ثانية واحدة، زي تشاينا وزي برازيل، بس تشاينا عندها single child policy فمختلفين عندنا، وبعض الدول يعني أمريكا 30% إحنا around 80%. نفس الحكاية. لو بصينا هنا أهو we have a very high rate. Dominican Republic, Brazil إحنا ده كان 53%. We are now from 70 to 80%. لدرجة indications of cesarean section دلوقتي بنقول إن it's either indicated or on request or bad decision making. On request and bad decision making يمثلوا 80% من السيزاريان sections اللي موجودة. في عندنا we peddle this. There's a lot more that can go wrong in natural birth than can go wrong in C-section for the mom. So the mom is more willing to take something happening to me. الأم تقول لك أنا يحصل لي حاجة أرحم من البيبي يحصل له حاجة. This is false. The complications to the baby are higher من السيزاريان section. Okay? طيب افرض واحدة طلبت cesarean section we should evaluate the risk and benefits. الكوموربيديتيز. In comorbidities أنا عندها ضغط، عندها سكر، عندها حاجة it's better to deliver vaginally عكس اللي بيتعمل. BMI, obese patients do not do well in cesarean sections. Future reproductive plans. في أمريكا in the United States لو واحدة طلبت on request تعمل cesarean بيمضوها إن مش هتولد تاني، بحيث لو ولدت تاني وحصل مشكلة ما حدش يقاضيهم بعد كده. Prior childbirth experience. ايه الاكسبيرينس بيجي قبل كده؟ البريفيوس سيرجريز اخبارها ايه؟ والعيانه البيرسونال فيلوسفي عنها ايه؟ المخطوط. طيب الريكوست اول حاجه convenience. الدكتور مناسب ليه يشتغل، عنده رايح الساحل يوم الخميس والجمعه فما فيش داعي ان يجي له ولاده يوم خميس او جمعه، فهو بيظبط قيصرياته الكلام ده. Fear of pain. This is wrong. ان احنا نولد واحده in pain this is unhuman. فعندنا المشكلة إن العيانة خايفين من البين. epidural service مفروض يحسنها. bad labor experiences. ومشكلة مش bad labor experiences لينا، هتلاقي ناس عمالة تحكي ده أنا ولدت طبيعي وحصل لي كذا كذا كذا. اللي بتولد قيصري رغم إن بيحصلها أكتر إلا إنها less liable إنها تكتب الكلام ده. Concerns about fetal harm from labor. الناس تقول لك البيبي مش هيستحمل الولادة. الأطفال بيستحملوا الولادة من ساعة الخليقة، من ساعة ما اتخلقنا، فمش فاهمين. لكن cesarean sections more dangerous هنقولها إزاي؟ خوف من urinary incontinence from labor and vaginal birth. Urinary incontinence is usually transient. Alright? وبعد كده الخطورة تقول لك إيه؟ أنا هاخد ولادة طبيعي وهقلب قيصرية، أنا مش عايزة الحكاية دي. البلانك سيزاريان سكشن بيبقى له نون اند بوينت، الدكتور يقدر يوضح، لكن نقدر نعمل اندكشن. We will avoid post-term pregnancy. Induction برضه will avoid. reduce the risk associated with unplanned surgery. مش هتجي الساعة 3 الصبح العينة واكلة. Prevention of late stillbirth بس برضه أقدر أعمل induction. Reduction in non-respiratory neonatal disorders. يعني بالذات لو كان في hypoxia أو كده الناس بتخاف منها، لكن دخول الحضانة من respiratory disorders بيزيد 3 أضعاف مع cesarean section. يعني cesarean section بيؤدي إلى إن البيبي يخش الاي سي يو 3 أضعاف الحكاية دي. اوكي. الديسادفانتج it's not natural بيزود الريسك اوف anesthetic complications. recovery period اسرع. يعني كلنا شفنا العينه اللي تيجي بعد اسبوع من بعد القيصريه لسه شكلها تعبان، تيجي اسبوع بعد الفاجينال ديليفري كانها ما ولدتش خالص. There is morbidity related to surgery. Neonatal respiratory problems بتزيد، وطبعا احنا عارفين الريسك اوف placenta accreta later on والريسك اوف rupture uterus والكوست. امريكا متضايقين ان تلت الولادات بقت قيصريه. They are very unhappy. احنا عندنا 70 ل 80% وفي بعض المحافظات 90% وكده. دي الخطوره. This is bad, this is good. Maternal mortality is 4 times higher in cesarean section. Fetal death in future pregnancy is 1.6 times higher. Placenta previa 1.6 times. Rupture uterus 42 times more common. Respiratory problem 6 times more common. Hysterectomy 44 times more common. Urinary problems 25 times more common. Bladder injury 36 more times. لكن incontinence أقل، perineal pain أقل. يبقى إذا increased cesarean section عاملة مشاكل كتير. ده مشكلتنا. شايفين احنا طالعين من سنة 2000 relatively recently من 20%. we are now 2014 كنا حاجة و70% واحنا دلوقتي في الحتة دي. we are ridiculously high. هل الكلام ده عشان الاستشاريين هم اللي بيعملوا قيصرية فيها مش فاضيين؟ ابدا. حتى الريزيدنتس بيعملوا high rate of cesarean sections. we have a huge rate of cesarean sections. احنا عندنا مشكلتنا ان عشان عندنا ناس عملوا سيزاريان 50% rate of cesarean اللي هو previous cesarean section. previous cesarean section انها تولد فاجينال في مصر نسبتها قليله، فاصبح دلوقتي عندنا ناس كتيره اوريدي عامله سيزاريانز فبقى ميؤوس منهم. طب ايه اللي نقدر نمنعه؟ ان احنا نعمل elective induction بدل سيزاريان لو المواعيد عايزين معاه. safe oxytocin we encourage الناس انهم يستعملوا pump. good fetal monitoring. obstetric skills اللي هي تقريبا انهارت لازم نرجعها. وجود pain management. في جامعة عين شمس البرايمري سيزاريان سيكشن ريت دلوقتي بقى اقل من 20% تاني، ان احنا عملنا policies بتاعتنا. On the long run, a late effect of cesarean section, placenta مش سليمة, cesarean scar defect, numbness or pain, endometriosis hernia, adhesions and bowel obstruction, chronic post-surgical pain وهنوصل لها كده. الكرونيك بوست سيرجيكال بين اللي هي العينه تيجي تقول لك انا عامله قيصريه من سنه ولسه الجرح بيوجعني. This is a chronic pain. العينه بقت chronic pain syndrome. This is very common دلوقتي. ايه اللي يزود الكرونيك بين؟ young age. كل العيانين بيعملوا سيزاريان young age. female تزودها. obesity تزودها. psychosocial factors تزودها. يبقى احنا بنزق ناس كتير على chronic pelvic pain مدى الحياه. والكرونيك سيزاريان سكشن ممكن يعمل persistent health problems, fatigue, low back pain. تقول لك العيانه من ساعه ما عملت قيصريه وانا مجهده. ده قيصريه بقى لها كده، والله عملت سي بي سي وكان نورمال بس انا تعبانه. chronic pain, scar pain او chronic pelvic pain عندها pain ما بيتحسنش وهكذا. دي كلها زي ما شايفين الانكريس ريسك اوف بين. البين بيوحش المود، جالها فيرتيجو، جالها تايردنس. فالكرونيك بوست اوبرتيف بين اللي هيقعد معاها بالسنين ما هواش حاجه كويسه. على النيو بورن السيزاريان سكشن بيالتر ذا اميونيتي، بيزود اللايكلود اوف الرجي، اتوبي، ازمه والجت مايكروبيوم دايفرستي. فليتر اون في higher risk of obesity. لقوا ان المولودين by cesarean section عندهم 50% increased risk of obesity لان الميكروبيوم مش كويسه. وكلنا عارفين دلوقتي العيال كلها اوبيز، واحنا صغيرين كان ما فيش حد اوبيز، كان العدد الناس الاوبيز يبقى قليل جدا. يبقى ال first few months of life colonization of gut microbiota مش هيحصل لان احنا ولدنا باي سيزاريان، لدرجه ان في ناس بتقترح ان تاخد مسحه من الفاجينال سكريشنز من المذر وتديها للبيبي اورالي عشان نمنع الكلام ده. لسه اندر ترايل ان احنا ازاي نحل ان عيانه ولدت باي سيزاريان سكشن. نيورو ديفلوبمنتال هنا اللي بتعمل سيزاريان سكشن اللايبيليتي ان البيبي يطلع مش كويس نيورولوجيكال بيزيد 30%. اللي يحصل ADHD وكده. ما نقدرش نقول ان ده كوز ايفكت لكن بنلاقي ان الولودين فاجينالي less liable ان يبقى فيهم الحكايه دي. يبقى دي كلها ريسكس ممكن تحصل يمكن اتكلمنا عنها. فهنبص مع بعض على بعض الكيسز، والكيسز دي كلها حقيقيه، مفيش ولا كيس منها كده. These are true patients حصلوا فعلا. عيانة 28 year Paula 2 اتعملت 2 cesarean sections مش فاهمين ليه. عندها Wilson's disease which is a copper transfer disease. بتاخد بنسلامين، بتاخده on and off. من غير بنسلامين she will die. المهم she is pregnant at 35 weeks. دخلت in labor، عملت cesarean. الانستيزيا زق الليفر على decompensation. She never recovered consciousness. حتى عشان كده اللي عندهم severe liver disease بنقول للنايب ولد طبيعي تحت اي ظروف. الليفر ما بيستحملش الميجر سيرجري، فدي جالها بعدها ماركت اسايتس، ووند احصل disruption، فيستولا، جالها بيريتونايتس and she died. لو ما كانتش عملت سيزارين في الاول ولدت فاجينال، لان هي عملت 2 سيزارينز، الدكتور غصب عنه، فدي مشكله. 27 year old para 1 عندها veno occlusive disease of the liver with bleeding varices. عندها Budd-Chiari syndrome in labor، واديناها octreotide عشان نوقف bleeding and we stopped the bleeding. نجحنا ان احنا نوقف bleeding. المهم عملنا cesarean section والعيانة never regained consciousness. Never regained consciousness. She died. Alright? Why؟ نفس الكلام ان الليفر was decompensated كده. لو ما كانتش عملت cesarean section اول مرة كان هيبقى ارحم بكتير. نيجي بقى حكاية cesarean better for the baby. 27 year old is convinced to have elective cesarean section because it's better for the baby. قال لا أحسن للبيبي. Next pregnancy حصل rupture scar at 34 weeks. البيبي saved لكن طلع CP. طيب لو كانت ولدت أول مرة vaginal كان تاني مرة هيحصل rupture uterus؟ No. كان تاني مرة البيبي هيطلع كيبة. إذن cesarean section is safer for this baby but worse for the next baby. معايا ولا لا؟ وحتى السيفتي فور ذيس بيبي artificial، لان انه يخش الحضانه من respiratory problems هتزيد 3 اضعاف، فما هياش حاجه كويسه. 32 year old para 2 cesarean section عندها lupus for 3 years. بكره ان شاء الله في اخر اليوم هيبقى فيه 2 interesting cases على lupus in pregnancy. اللي يحب يشرفنا هيبقى عندنا panel discussion من ناس كويسه جدا جدا. المهم previous 2 cesarean sections عند 34 weeks جالها rupture membranes واحتاجنا نعمل cesarean. العيانة is in a flare. عندها polycerotitis and lupus cerebritis. polycerotitis يعني عندها peritoneal ascites وعندها pleural effusion. It's a very dangerous condition. وجالها lupus cerebritis بقى كأنها عندها psychosis. The patient مربوطة في السرير، قطعت الرابطة وراحت قطعت الجرح بتاعها ومزعت عضلاتها. ومزعت عضلات بطنها كويس. فدلوقتي بقت الابدومين اوبن وبينزل اسيتيك فلويد ومعاها بلورال افيوجن حطينا فيها تيوب كويس. الوند انفكتد واضطرينا ندي سايكلوفوسفاميد رغم ان احنا بنكره السايكلوفوسفاميد في الحمل والرضاعه كويس. اضطرينا نديليت واديناها بعدين. ايفنشلي اديناها بعد 6 ويكس عن امبروفد، لكن لا زال عندها بطنها بتجيب اسيتيك فلويد. يعني عيانه ماساه لان السيزاريان سكشن از ان اوبريشن فتحنا فيها الابدومن. 29 year old para 2 عندها بلاسنتا اكريتا. زي اي واحده قالت مش هقعد في المستشفى، عندي عيال في البيت. طيب تعالي اول ما تنزفي. المهم جالها سيفير بليدنج، جايه شوكت. العيانه دكتوره عشان تبقوا عارفين she's a doctor. alright. جالها acute tubular necrosis did not resolve وبتدور كانت على دونر ساعتها. معايا ليه؟ لان هتعمل ايه؟ على بال ما جت shocked اتلحقت لكن the kidneys were damaged. فدي why did she lose the kidneys? She did not lose her because of this cesarean section. She lost it because of the previous. يبقى إذن the indications of cesarean section have evolved and it is being abused. It's more dangerous than vaginal delivery لكن في بعض advantages. Proper counseling, implementation of international guidelines, developing the will to change is paramount. Thank you very much.
Thank you, dear Professor Ayman Abnoor, for this interesting lecture. Professor Ahmed Rami.
دكتور أيمن، صباح الخير عليكم جميعا. احنا يعني بنهنئ بهذا المؤتمر الرائع، بنهنئ الدكتور حاتم والتيم اللي معاه كله يعني الجمال اللي موجود يعني.
صحيح.
وبنشكرك على المحاضرة الجميلة يا دكتور أيمن، كعهدنا بيك دائما يعني. أنا بس I have a question. هل البوليسي بتاع المينستري اوف هيلث اند بوبيوليشن في فكره ان هم they are pushing forward للميدويفري والدليفري، هل ده هيقلل السيزيريان سكشن ريت وهيحسن الاوتكم ولا؟
هو دلوقتي ده هيخلق بريشر على الدكاتره، لان احنا كنا we were against midwives. We were against it. Why? لأن البروبوزال بتاعهم في الميدوايفري في مصر إن الناس دي تبقى لايسنس تشتغل unsupervised. إحنا كنا عايزين يشتغلوا part of the team، وإحنا يمكن مع الشغل مع نقابة الأطباء الدكتور أسامة ونقيب الأطباء حاولنا كتير قوي، لكن حاليا they are now pushing لأن ليهم ناس في مجلس الشيوخ، والعذر بتاعهم يقول لك العيانة اللي عايزة تولد طبيعي ما بتلاقيش الدكتور اللي ولدها طبيعي. فده هيخلق pressure على الأطباء. هل هو هيحصل improvement؟ I have no idea. لأن التريننج اللي كان مقترح 6 months إلى 2 years and we think this is not enough. فهل هنرجع للزمن ان هيبقى العينين جايه برابتشر يوترس والعين جايه بفيتال ديستريس والعين جايه ببروبلمز؟ we don't know. احنا نحب انهم يبقوا يشتغلوا في المستشفيات under supervision، لكن برضو دي فيها disadvantage للجونيور دكتورز، ان الجونيور دكتورز ممكن ما يتعلموش سكيلز. we have a problem. حتى عندنا يمكن دكتور حاب عبد الرحمن اللي هي مديرة المستشفى قالوا له لازم تمرني الميد وايفز. قالت لهم انا يا دوبك العينين عندي كافي ان انا امرن الاطباء. ف it's a problem. It's a problem لان احنا we are here doctor centered، ف we are really not very happy بالحكايه دي. We are not happy باللي هم عايزين يعملوه. لو هم هيبقوا part of the team ممكن.
ويعني احنا نتوقع انه هيحصل يعني ولا
هيحصل او لا دي في علم ربنا سبحانه وتعالى، لكن هو النقابه against unless احنا عملنا اجتماعات وانا بارت كده قلنا لو هم هيبقوا part of the team وما ياخدوش رخص فهم بيخشوا بباب خلفي. طب هنديهم رخص فقط في الاماكن النائيه اللي هي underserved، الوادي الجديد مش عارف حتت في الصحراء، بس في قانون في الدوله وانس انا خدت رخصه في الدوله لمكان خلاص من حقك تشتغل في كل حته. ما فيش حاجه اسمها انا اتخرجت من عين شمس ما اشتغلش في اسكندريه، مفيش حاجه اسمها انا خدت رخصه قياده في اسيوط ما اسوقش في القاهره. فوانس انهم دخلوا it's going to be over. لكن مع اول بروبلم قضائيه هتبان التشالنج، هتبان التشالنج. Thank you.
Thank you, the Professor Ayman. Thank you, Professor Ayman. We have some changes in our program because some of doctors apologize. Professor Hassan Salam apologized because he has his brother is sick. Now we have Professor Salah Rashid, Professor of Obstetrics and Gynecology, Sohag University, and he will address us about beginning of human life, a great condom.
Assalamu alaikum. Thank you, Mr. Chairman, and thank you for all the organizing committee of the ASOG meeting, and particular for Professor Hatim for inviting me. My title today is about the beginning of our human life, whether it is a great or simple puzzle. I hope at the end of this presentation to unreveal the answer of this question. Whether it's matter to know when our life begins, actually yes. This issue has acquired new dimensions, particularly during the last years, because we have the ability to manipulate early in the beginning of the human life. The issue is important for certain procedures, including legalization of abortion, during IVF, during embryo research, and during selective fetal reduction. Actually, the answer of this question involves a set of biologic, ethical, and religious disciplines. The proper definition of the start of the human life is to combine all these variables together. Actually, this combination seems too impossible because of one reason, because of the different ways of thinking between these three variables. The science deals with the physics, with the palpable things. The religion deals with the spiritual and metaphysics. And lastly, the ethics deal with the personal attitude, personal behavior, and with the personhood. It's in the vast majority of cases, the science and the religion didn't meet at certain point. They try either to dominate or ignore each other. The religion does not need rationality. It's based on faith, and no further proof is needed. On the other hand, science, the scientific idea should be tested and verified. Let us first to discuss the scientific approach, whether our life actually starts at fertilization or with the formation of the zygote or at implantation. There is a great debate. However, most authors agree that our life starts with fertilization, and they have many rationale. The first, the zygote is the first who created a genetically unique organism. The second argument that anybody can be traced back only to fertilization, which is the biologic point of existence. Actually, before fertilization or before zygote formation, we are not existing. On the other hand, many say this is not true. The zygote is the zygote is not the early stage of our human life, and they have many arguments. They say that the size of the zygote is exactly comparable to the oocyte. So the zygote is not an organism, it's just a cell, and no new life began. However, this rationale is exceedingly full, okay, because the size does not matter. The second was called the twinning argument. They say that in cases of identical twin, the zygote will divide. And if the zygote is a human being, all of us know that the human being cannot divide. However, it is a case like it's analogy to the worm that can divide into two. So division of the zygote does not obviate its humanity. The second argument is the zygote lacks genetic information to develop into human system. Yes, this is true. The genetic material in the zygote is not 100% formed. However, if we thought like that, we are thinking like a manufacturing. We're considering the zygote is manufacturing, so the cake is not a cake till it comes out of the oven, or the car is not a car till it leaves the assembly line. However, this is not true because the zygote is not manufactured. It generates its own characteristic, which if surely left uninterrupted, it will develop at the end to a full human being. Others says that our life starts at implantation with the formation of the full embryo. And they stated that the human genome, which governs our individuality and personality, only formed about 2 weeks after fertilization. Yes, this is true. And they consider that till 14 days of fertilization, the embryo is not a person, it's not a human being. However, this is not true, and there are many counter-arguments that the human life definitely occurs in stages, and the early stage of our life is the zygote. The second view, which is more dogmatic or more extreme, is a neurologic view. Who are supporting this view says that the human being has a unique electroencephalogram pattern and appearance of this wave or the signals denote that the fetus has a type of mental activity which is characteristic of a human being. And absence of these waves or absence of this mental activity obviates the character of being a human being. On the other side of the coin, death is defined loss of these EEG signals or waves. If we defined life and death by the same standard, so life is assigned by the appearance of these EEG waves at about 24 weeks. So, who are supporting this view, they didn't consider a fetus below 24 weeks as a human being. The last is ensoulment and religious views. All of us know that soul is the principle that gives life and animation to the body. In cases of Islam, actually, it's both Quran and the Sunnah were indecisive. They consider that the life begins with fertilization. Others consider at what's called soul breathing. Our life starts about 120 days of conception. On the other hand, Christianity was more clear in this situation. Christianity assumes a personal and moral continuity since fertilization. So consider the point of fertilization is the start of our life. However, what has been criticized in Christianity is that Christianity says that human beings are created as ensouled bodies, or the soul it's embedded with at the time of fertilization, and this point is highly criticized because about all of us know that 70% of the zygotes never implant, a condition which is termed as subclinical pregnancy loss. So many persons who are interested in the religions question the enormous loss of souls. The second, in cases of identical twin with early division of the zygote, whether the soul will split again, this is okay. It's a make a large question mark. The last is what about the bioethics and its attitude regarding the start of our life. All of us know that bioethics is a branch of philosophy which assigns the human behavior as true or false. The main problem of bioethics is what's called ethical relativism. That means that the same action may be morally accepted and morally right in one society, and it is morally wrong in the other society. And there is no standard to dispute, there is no standard to resolve these moral disputes. The most ethicists consider that the embryo, the fetus, the zygote is a person, but indivisible from the mother, inseparable from the mother. They added that the embryo has an independent moral status from the mother. Come a very important question regarding the bioethics, whether the zygote is a human with potential or a potential, just a potential human. Most ethicists say that the zygote is a miniaturized per individual. However, not all bioethicists agree upon that, and others plays with the semantics and say that the zygote is what's called the human in being or marginal human. This makes the situation more complex and more sophisticated. What about legalization of abortion? What the bioethics says about legalization of abortion? Whether abortion is destruction of tissues or a kind of murder or homicide. Let us to view this movie in about half a minute, what's called the silent scream, whether during evacuation, during destruction of the fetus, whether it is the fetus feels pain, whether it is suffer like us or not. Okay, we can see that here. However, the video shows clearly the suffering with the fetus. It's opening his mouth like screaming during its evacuation, and it's trying to go away from the abortifacient device. What slide? خلاص يا خلاص يا. The one issue is fetal reduction, selective fetal reduction. The PIOSS ask you or me, which one of your children you will select to kill? Whether you will kill the good or the bad kid, I think nobody knows. Lastly, this disposition or eradication of the frozen embryos. Mean okay? No, this is not good eradication of the frozen embryo, because they consider embryo is a person, and eradication is exactly similar to murder. And they ask another question, whether IVF actually destroys or creates life. Definitely it creates lives, okay? But on the other hand, for a chance of one child to live, many others are killed or left to die. On the other hand, others say that there is no problem regarding eradication of the embryo, because the embryo without a uterus, it's exactly similar to the cell that may be shed from the body. Our take-home message is that at the end of this presentation, whether you consider the puzzle of the beginning of our life, whether it is a difficult or simple question, actually the answer will depend upon your attitude. Whether this is number 6 or number 9 will depend upon attitude, will depend upon which side of the river you are standing. And lastly, it's our time to confess that in medicine there is only one truth, but actually this trust may have two faces, and unfortunately the two surfaces or two faces may be true. And lastly, I hope that our God to forgive us if we have committed murdering regarding fetal reduction or regarding eradication of the frozen embryos. And I am always closing my presentation with this immortal statement, life is finite. All of us are finite, however, knowledge is infinite. And many thanks for all of you.
Thank you very much, Dr. Salah. Do we have any question, please?
اهلا دكتور صلاح بيه، انا احمد رامي من جامعه عين شمس.
شكرا يا بيه.
ربنا يخليك. طبعا احنا استمتعنا جدا من حضرتك قلته، وحضرتك قلت معلومه مهمه جدا ان you defined life as an EEG activity which starts at 24 weeks.
Yes.
This is marvelous. انا هسأل سؤال، هو سؤال يعني بقالي 30 سنه ببحث له عن حل. اكيد حضرتك قريت في الموضوع فيمكن تساعدني. احنا نفوس ولا ارواح؟ ده السؤال الاول. وده هيعتمد عليه حاجات كتير قوي بعد كده. السؤال الثاني الانالوجي بتاع الديسبوزل بتاع الامبريوز، ده مش بني ادم.
You consider
ده مش بني ادم.
not a human
هل انا
being.
لو في حاجه طايره ومسكتها يبقى انا قتلتها؟ هو لسه مش موجود، هو كان هيبقى موجود، هو ما اتوجدش لسه، مش موجود، هو مش موجود.
اوكي.
فاديني لو عندك يعني تقدر تساعدني في حل هذه الدايلما اللي كلنا عايشين فيها.
طبعا.
والحاجه الثالثه بقى هي دار الافتاء. انا عارف ان الساعه 5 النهارده بعد بالليل في سيشن جميله قوي دكتور شريف مكاوي يعملها عن الموضوع ده. هل لما العيانه تيجي تقول لحضرتك انا معايا افتاء او معايا فتوى ان انا اعمل ترمينيشن، هل ده له اي قيمه طبيا او له قيمه قضائيه او قانونيه، ولا ده حاجه كده يعني في خيالها؟
ابدا من النقطه الاخيره حضرتك اللي هي الافتاء اللي حضرتك قلت عليها، تمام؟ لان هو ده بندخل بقى في الديبيت بين الريليجن والساين والبايو ايثكس. بتوع الساينس بيقولوا ان religion should have a spiritual not biochemical rule. المفروض بتوع الإفتاء ما لهمش دعوة بالtermination or so on. الدكتور or obstetrician يحدد according to the general condition of the mother whether this pregnancy can be allowed or should be terminated. This is the first. The second, whether the zygote is embryo or not. مع الأسف الفيديو اللي اتعرض كان بيعمل destruction of a fetus about 26 weeks. It's okay, sorry. 26 weeks, he want to kill him before delivery. It's okay, it's okay, it's okay, it's okay, okay. He killed him. What's the difference? Why he is killing him inside the uterus? Why he didn't leave this fetus to deliver, then kill him? What is the difference? You can answer me. What he want to kill him?
هو بلاد الفرنجة لا تسمح انك تعمل ترمينيشن لعيل صاحي. لازم العيل ينزل ميت عشان لو امه شافته صاحي دي بيعمل تروما ليها بيعمل
because it's not allowed. Okay, it will be a crime to be kill him after delivery. But what's the difference? To kill him inside the uterus or to kill him outside the uterus? Whether the place is the problem, whether you killed him in the room or killed him in the street, it's the same policy, the same thinking. Okay, so it's a great debate. But for me, personal, the human life is just a stages, and the early stage is the formation of a genetically new organism, and this new organism is the zygote. It's just a stage, like the newborn, like the infant, like the adulthood, like menopause. It's a stage of our. This is my opinion.
Thank you very much for the talk. It raises lots of.
اللي احنا ارواح ولا نفوس؟ I think both. طبعا لو احنا ارواح من غير روح it's nothing. طب احنا نفوس. الاثنين يعني الاثنين. انا مش يعني السؤال ده يعني common مش حاجه specialized. ماشي يا باشا هو البيبي يقول لك الساعه 5.
I know there is a session later, but it's a very interesting discussion. I wanted to comment just about the point. What is the difference between doing fetal reduction or why would you do it or not? I think the biggest problem is that it depends on whether you look at it from a legal point of view or ethical point of view. Ethical point of view, you're absolutely right. They are the same from an ethical point of view.
Yes.
But what happens, at least in most of the Western countries, is that they follow the legal side of things.
Yes.
And of course, the baby or the fetus does not have a legal right until it is delivered and shows sign of life. If somebody is pregnant and they are involved in a car accident, and then the baby dies in utero, the punishment for the driver is totally different than if the baby...
If she was not pregnant.
No, if the baby is delivered and just gasps one gasp and then dies. Because the other one is manslaughter, because there is an individual. The first one is not. So the legal side of things is very different abroad than
from the ethical.
Yes. Ethical, it's, of course, it varies from one place to the other.
You consider that the start of our life zygote or later on?
Personally, and you mentioned also personally. So, I mean, I know there is a big session for this debate later on. I personally think that even from the sex selection point of view, I personally don't accept it. But this is my personal view. And I don't accept fetal reduction. I don't accept, but this is my personal view, if you want to know my personal view. But my personal view is of no value, except to me.
There's a problem. If actually the zygote or the embryo or the early embryo is a human being, we should all pray to our God to forgive us. Yes, and thank you. Yeah.
Question, Professor.
I have two questions for you.
Thank you.
Thank you for that presentation. The first question, would you rather have an unsafe abortion or a safe abortion? And then what's your comment as we embrace stem cell research?
Sorry, the second question I didn't understand. The second question.
We have a lot
Second
of
point.
women dying from unsafe abortion.
Yeah.
Would you rather have unsafe or safe abortion? And what's your comment as we embrace more and more of stem cell research?
Yes, I think I'll start with the second point regarding stem cell. This issue, because of the constraint of the time, okay, I didn't mention it here, okay, but it's very important. But also the stem cell research, okay, it has a many ethical debate. Actually, it's not seated. It looks like this presentation, which is full of debate. Okay, I think here in Egypt we don't have legalization for abortion like in the Western countries, and we only allow abortion for preservation of the woman life. Okay, in cases of severe medical diseases or so on, or if there is the fetus is incompatible with life. I think in the time is changed in Egypt, particularly in the last 30 years, and all the women seek what's called safe abortion, not like before. And I think our great professor has more information in this issue better than me.
Thank you, Dr. Salah. Please, Dr. Ahmed,
Thank you.
introduce Professor Anil.
And also I want to rest assure you that we have a later on session today for this ethical, medical, legal, and religious point of view for these moral important things. It's a really hot topic. Now it gives me immense pleasure to present Dr. Ann Beatrice Kiara from Kenya. When women talk about women, it will be much better. She loves women and she works as a senior lecturer in the Department of Obstetrics and Gynecology in the University of Nairobi. Also, she is the president of the African Federation of Obstetrics and Gynecologists. She's totally advocate for her work, for women. She loves to be everywhere, nationally and internationally, for the development and quality of women life. Please.
Dr. Kiara is the president of FIGO.
Good morning, everybody. Good morning. I really need to know that you're there so that we can walk together and really appreciate this invite to attend your Congress. I've actually left a Congress going on in Alexandria, but I was determined to be with you. Great. So we will be looking at challenges and solutions in women's health in Africa. I have one part that will address challenges first. And I want us to look at women's health with a life course approach. Birth and gender beginning. So we've just had the debate from the previous speaker. In my community, when a boy child is born, the women will give accolades 5 times. When a girl child is born, it's done 3 times. So you can already begin to see the differences in gender and social norming and the destiny. Then we have childhood, which is relatively quiet. And you get to puberty and have to begin to speak about menstrual hygiene and health. I come from a community where harmful cultural practices still exist. Early marriages, female genital mutilation, and even violence against women. Gender disparities continuing. Then women in reproductive age, reproductive planning and fertility intention. So is she going to give birth? Is she going to have an abortion? And is she going to be allowed to use contraception? And of course, the maternal, neonatal, child, and adolescent Are they going to have morbidity or survive? We have aspects related to infertility, STIs and HIV, reproductive cancers, menopause. But again, today we have different contexts: communicable diseases, non-communicable diseases, mental health, which is a rising phenomenon, particularly following COVID, and then climate change and its current effects on all of us, particularly malnutrition, vector-borne diseases, respiratory diseases, and depletion of our natural resources. But we cannot talk about women's health if we're not addressing health inequities, and you will see this. The normative environment, here we are speaking to legislature, policy, guidelines, job aids, curriculum, technologies, and how much of technologies we are bringing in. In our current context in Africa, trade and manufacturing. Health workforce is a critical arm, and I can see their younger practitioners here. Do they want to retain being in obstetrics and gynecology, or are they getting burnt out? Or are they migrating, particularly in Africa, we're suffering from brain drain? The resilience of our health system, and therefore looking at a woman even more holistically and not fragmenting her. Global health security, biowarfare, technological crimes, data insecurity, drugs, and even human trafficking. I have put this so that you can all reflect. I come from a place in Kenya. In the northern part, there are girls there who don't even want to have their periods because they have period shame and would rather be continuously getting pregnant. That community on the extreme left, the Dasanach. When you see a teenage pregnant girl, in our community, you must ask the question behind that girl, what is her story? For some, it's rape. For some, it's lack of basic needs. For some, it's poverty. The living standard is so low that they peddle their bodies. And for some, she dropped out of school, and the next thing, she's pregnant. FGM increasingly is becoming a practice that's going underground. It hasn't stopped. We had said in my country we want it abolished by 2022. It's still continuing. And in some countries and some areas in Africa, up to 99% have FGM and are betrothed to become early brides. Gender-based violence still exists. But I want you and I to reflect on the populace we don't seem to see. Persons living with disability, persons living with HIV, persons who are in rural populations, urban informal populations, and the trials that they go through. It is a serious problem when discussing women's health. Adolescent birth rate. I have given statistics there just to show you globally. In the adolescent birth rate, it's about 42. But where I come from, it's at 99, and in some communities, even over 150. Child marriage. On average, it is 4% globally. But in sub-Saharan Africa, it's up to 9%. So maternal and newborn mortality, Africa and South Asia bear the brunt. Africa region accounts for 70% of mothers and newborns who are dying. We're not very far from you. Yet, our performance is abysmal far. What are the complications? Hemorrhage, high blood pressure issues, puerperal sepsis, abortion, obstructed labor. Things that we can treat. The late Mohammed Fatala said, we know what's killing our women. The issue is, do we value them? We have 6,300 babies dying in the first month of birth. an estimated 2.3 newborns equally dying. We have the obstetric transition model that educates each one of us. And you can see on the extreme right, I have shown you the various causes of death. But let's focus a little bit on the left picture. In Africa, we have maternal mortality that ranges anything from 300 per 100,000 to as high as even 1,500 per 100,000. What does it mean? We're not nursing our women and children, or we have poor access and poor health systems. But as you evolve, and I want you to reflect on Egypt's maternal mortality and neonatal mortality, you will realize as quality of care improves, outcomes get better. So we're struggling between stage 1 and 2, whereas in these upper northern nations, you're probably around stage 4. And in high-income countries where it's less than 10, they're in stage 5. We have a lot of work to do. Again, look at the inequities. Stillbirths. Stillbirths more oftenly are an event of intrapartum care. Again, Africa is painted red. We have much more stillbirths, between 12 and even going as high in some regions to more than 25 per 1,000. Will we really reach sustainable development goals, where we should be having it less than 12 per 1,000? We need to reflect and think. I've displayed to you here the maternal mortality ratio just to show you the variance in countries, which I have alluded to using the obstetric transition model, and how it ranges in different countries in Africa. Availability of the health workforce, a big problem. WHO says you must have a minimum of 4.45 persons per 10,000 populace. Africa is struggling to just have 1 per 10,000 population. So put into actual context. I work in a labor ward where we have roughly 80 patients per shift that the doctor has to see. Yet you may have only 3 clinicians. Will we possibly give quality of care, even if you have the intellect? These are our realities. Again, I want to reflect, considering all those arms I spoke about with the life course approach. Are we having clinicians who are fit for purpose in the current context today? They know about climate change, they know about the COVID and the emerging diseases, non-communicable diseases, communicable diseases. The epidemiology of disease is changing, and we must move together. A lot more has been done in curative medicine. We can't afford it, so we want to move upstream, primary healthcare and universal coverage. But what's the scope of practice? And should we rethink a multidisciplinary and multi-sector approach to women as a holistic manner? Again, guidelines, budgets, are they being done in your country? Do you have strategic directions? Do you have trainings and mentorship? And do you even have access and coverage and quality? This is simply putting the health system on the extreme right, showing you all those building blocks. But my question is, are we really reducing the burden of disease and the risk factors and providing quality of healthcare and therefore quality of lives? I don't think so. Access to life-saving commodities, again, a big problem. When you talk about magnesium sulfate, I have to grapple with what's its concentration and when does it get to the patient's bedside, and is it actually correctly used? When I think of PPH, heat stable carbetocin and tranexamic acid and UBTs, are they really getting to that patient who needs it most? Oftenly not. Blood and blood products. When I need it for PPH, it's not readily available. Availability of family planning, something I see as a development agenda. Avert a pregnancy, save a woman, let her nurture the few children she has. Again, you can see the variance of availability. Availability to emergency and basic supplies. Again, you can see in Africa the variability. We should be having this at 100% in all our facilities, but this is not my reality. That's my reality. May not be very clear, but I have a beautiful health center in the middle of a national park, which is plagued with animals. When it rains, those are women struggling to get to that clinic. That's one of our realities. So you may talk about access. Can she really get to where she needs to get help? But we don't lose hope. Some of us have taken it upon ourselves. Provide beds, provide incubators, provide care. But how many of us can step out, even where we work? Because for me, this is the challenge to all of us. We tend to be in tertiary facilities where it's very nice, readily available. But do these women deserve equally the best or half measures? Women who attend antenatal care, again, you can see the African picture. It's dismal, particularly in sub-Saharan Africa. Skilled birth attendants, again, Africa is a question mark. Why aren't we having skilled attendants? Food security and nutrition, and particularly now with climate change. Direct and indirect effects on pregnant women. Africa is not on track, but what are we doing to make a difference? Anemia. PPH to me is a knee-jerk activity. We need to move upstream and address anemia and all its causes. Nutrition is the first, followed by chronic diseases. What are we doing about it as a collective? Data. Data does not lie. I think I've just given you snapshots on challenges that we do have in Africa. And we need to walk together. But we also tend to ask harder questions. If we're not adopting real-time data for decision-making, we're doing nothing. If we cannot even read the data that you and I put on the charts or standardize the tools, you're doing nothing. If we cannot benchmark together Egypt and sub-Saharan Africa, again, you're doing nothing. We need to reflect. These are just a few snapshots of the challenges. I will be back later to give you the solutions. Thank you very much.
Thank you, Dr. Chiara, about this interesting lecture.
And now for our next speaker, Professor Dr. Amr Assam, the star in medical education and the eminent lecturer. His talk is under the title of Primary Postpartum Hemorrhage Decision-Based Adapted Guidelines.
Hello? Okay. Good morning, everyone. Dr. Maher. Wish you all a nice day and a nice conference. And my talk will not be different from Dr. Ann Piatra's talk, because my entire life, my dedication was to fight for maternal lives. So I will be addressing the same issue of maternal mortality, but from a very different point of view that may create a lot of controversy. Now we know that maternal mortality is unacceptably high. And we know that almost 95% of maternal deaths occur in low and lower income countries. And we know that we need skilled workers, and we know that we need doctors who understand and implement clear guidelines in order to save maternal lives. Now, the maternal mortality rate in high-income countries is 13 per 100,000 live births, while in low and lower income countries, it is as high as 430 per 100,000 live births. While both of us, the doctors in the north and the doctors in the south, they use the same guidelines, because we like it or not, most of our doctors, at least in Egypt, either they are sitting for MRCUG, or they already got their MRCUG, or they are planning to sit for MRCUG. So they are so well oriented with the British guidelines. However, these guidelines, the Royal College tells you that these guidelines are developed primarily for clinicians working in the UK in consultant obstetric units. They are not appropriate for our hospitals and facilities. So we had to adapt the guidelines. At the end of the talk, I can tell you who adapted them. But we have to adapt them. We have to remove using the MRCUG or the Royal College guidelines and start developing our own guidelines that suit our facilities and our practice. So this is what we did in the primary postpartum hemorrhage to make the guidelines more decision-based and adapt them. Evidence-based medicine. This is what the guidelines should provide. But there are two pillars for the evidence-based medicine: the information and the decisions. The information, this is like, I'm telling you, there is a school ahead. I didn't give you any decision. I just told you there is a school ahead. It's up to you what you want to do here. But in our communities, we need decisions. We need to tell you, stop, turn left, turn right. These are road signs, not road marks. So we try to develop the guidelines to be more decision-based rather than information-based. Decisions mean clear-cut. When you see an objective sign, you have to perform a clear-cut decision within a time frame which is evidence-based. So, the next is why women die. If I ask anybody in the hall, most probably he will tell you there is hemorrhage, there is preeclampsia, there is sepsis, there is unsafe abortion. No, 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 this is a deception. This is the first deception. Women don't die because of hemorrhage. Hemorrhage is a condition that may lead to maternal death. If she dies, this means that the condition that may lead to maternal death did lead to maternal death. Why? What is the cause? The cause is decisions. It is either an improper decision or delayed decision or inadequate decision. And to make this further clear, in our communities, in our facilities, we need doctors to start acting once there is a shock eliciting event. Please take care of the words very carefully. We have a pre-shock phase, and then we have a shock phase. And the shock phase in obstetrics, 2 stages only: compromise and life-threatening condition. Okay? We need our physicians to start running when? From the very start, because we have poor facilities, we have poor laboratories, we have poor cross-matching and availability of the blood products. We have poor. So you have to be decisive, and you have to start very early from the start of shock eliciting event. If you don't diagnose shock eliciting event early, this is a delayed start. And this is one of the main causes of maternal death. And then you have to start your running. Running means what? Means that I need efficient replacement, and I need to arrest the hemorrhage, to stop the bleeding. Sometimes you don't start until the woman is hypotensive, and then you start running. Oh, her blood pressure now is 80/40, let's run. You diagnosed her a long time ago, but you did not perform the interventions. This is inadequate action or improper action. You are giving transfusion, you are trying to arrest hemorrhage by methods which follow the guidelines but will not stop the hemorrhage. And I will show you how. So identification of postpartum hemorrhage, we have many definitions. The Royal College opts for a definition of more than 500 milliliters. We did not find this logic because the same Royal College and the FIGO and the WHO, they all opt for 500 milliliters, and all of them tell us that bleeding is underestimated by obstetricians. So how come I use this definition? What we did, we used another definition, which is bleeding greater than expected. Bleeding that worries you or worries anybody in the labor ward. Now this bleeding means I am in a postpartum hemorrhage, I have to start action. I'm not gonna do anything, I'll just give you Trotonics and start cross-matching my blood. What's the big deal? Why wait? Any definition that relies on amount that we know is underestimated, any definition that relies on lab findings that we know do not reflect acute hemorrhage, any definition that relies on signs and symptoms of hypovolemia, which we know occur late in obstetric patients, all this is a late start. All this is a late start. So we had to go for the early start. Any bleeding greater than expected. What will you do? You will, next point, you have to assess the severity of hemorrhage. I'm quoting, and I brought you the picture of the guidelines of the Royal College. They tell you in this paragraph that visual estimation underestimates blood loss, that clinical signs and symptoms of hypovolemia occur late. They tell you in non-pregnant patients the shock index can be used and it's comparable to any other score. But this is all information. Where is the decision? What should I do? There is a school ahead. Okay, what should I do? Go 20, go 40, what? So this is evidence-based information, but no decisions. So what we did is that we adopted the evidence-based modified early obstetric warning score. This is what you should do. Once there is bleeding more than expected, you start running. You perform the meow score, you give the patient a score, and triage her. This is decision. This is not information. And then you have to arrest hemorrhage and effective replacement. We went through effective replacement and we found that the Royal College, and by the way, the FIGO and the WHO, classify hemorrhage as minor, major, and in the FIGO there is also the massive. In the minor hemorrhage, they give you all the measures you will do. Can anybody spot where is the volume replacement? Patient lost 700 milliliters blood. Our patients are not from Europe. They are all anemic. So you want the patient to lose 700 milliliters blood and don't replace the volume? Where is the blood here? There is no blood transfusion or blood component transfusion. And then in the major hemorrhage, what happens is that for major postpartum hemorrhage, you transfuse blood as soon as possible. That's when after 1,000 milliliter loss and ongoing bleeding, both of them, not one. She has to have lost 1,000 milliliters blood and she must be still bleeding, or there is clinical shock. And then they tell you if necessary or if clinically required. Well, it's definitely clinically required. If she lost 1,000 milliliters and still bleeding, it's clinically required. But at least in the major hemorrhage, there is blood component transfusion. And then the colloids, we have a big problem with colloids in our facilities. I will tell you now. Now we had to adapt these guidelines, and we adapted it, as the Royal College says, to uncontrolled hemorrhage or controlled hemorrhage. Minor, major, massive. This is after we control the hemorrhage, we see how much she lost. But while she's bleeding, one of two things. Either you controlled it or you didn't control it. This is very important for the mindset of our physicians. Because if there is uncontrolled hemorrhage, he wants quickly to go to the controlled hemorrhage. He doesn't want to stay here, to stay in the zone of uncontrolled hemorrhage. I will talk a lot about mindset and the phrasing of words. It's very important in the guidelines. So we did not use the terms minor, moderate, massive, except in the context of uncontrolled hemorrhage or controlled hemorrhage. Next, the estimated blood loss and clinical picture should be the main determinant of the need of blood transfusion, and we agree on this. Request early the anticipated amount, not the needed amount, because we have delays in the availability of requested blood. I agree. Encourage early volume replacement even for minor postpartum hemorrhage. This is in our part of the world, in Africa, in the low and lower middle income countries. We should transfuse blood once we are in a postpartum hemorrhage or transfuse blood components. And we have to rely on preset transfusion protocols. Why rely on them? Because we lack a hematologist, we lack a consultant in many facilities, and in many facilities we lack a specialist. The most senior is a senior registrar or a specialist assistant. And then our opinion regarding colloids is that we avoid them 100% in our facilities. Colloids are not used in any acute, it's contraindicated in acute bleeding patient. Colloids may cause coagulopathy, and in obstetrics, our patients are at the verge of coagulopathy. Colloids can cause all the risks of acute lung injury, acute kidney injury, circulatory overload. And I need to give colloids. I need to give plasma, which is the main colloid I will transfuse. So why waste my colloids? Because it's a limited volume. I cannot waste it with the hystril or the starch or whatever, and then when I need to give plasma, I can't give because the patient went into pulmonary edema. And then, so the way we see it is that there is a bleeding postpartum hemorrhage. She is uncontrolled, and then there is control, effective arrest of bleeding, so she later becomes controlled. When she is uncontrolled, we have to give volume replacement. How much volume she lost? She lost 700 mils. You have to give 700 in front of them. Okay? So this is volume replacement. But then, when bleeding is controlled, we continue the volume replacement, and then we start the lab-guided replacement if we have enough laboratory backup. So rules are simple. Volume replacement, whoever loses volume should take volume. Clinical picture is the main determinant of the volume I will give, including the estimated blood loss. And patients with acute hemorrhage will have normal hemoglobin, although they have bled a lot. So we made this simple table. It's the uncontrolled hemorrhage, the minor, major, and massive, controlled bleeding, and preset protocols. You have to obey them. If you give 4 packed RBCs, you give 1 plasma. If you give 6, you give 1 plasma and 6 packed RBCs, 1 plasma and 1 platelet transfusion. And cryo, by the way, if the patient is in uncontrolled hemorrhage, prepare. Because many research over the past 3 years states that it is better to maintain fibrinogen than to replace it. So we will maintain it, and this is a evidence-based protocol. And then after you control the bleeding, you can do lab-guided replacement. Lab-guided means that I will, after the patient is controlled, خلاص, she's in the ward, we do the clot, the PT, PTT, and the platelet count and the fibrinogen, and then we give accordingly. And while we are giving volume replacement, if the first round, sorry, if I can go back, yes, this is the first round. If I need a second round, I have to do laboratory. So it's better for you, if you don't have facilities, to control the bleeding, to arrest the hemorrhage within the first round of transfusion. Because the second round, I better do laboratory investigations. Laboratory investigations will be helpful in the platelets, fibrinogen, but not the hemoglobin. If hemoglobin is 10 and the patient lost 1 liter, give her the volume replacement of 1 liter. Don't think 10 is safe. No, acute hemorrhage is not reflected in laboratory results. Now the more important is, okay, thank you. I was going to talk about the interventions which are, خلاص I go, ما فيش حاجة أعملها. Okay, anybody has any questions?
So I want to present Professor Khaled Ismail, Professor of Obstetrics and Gynecology, Charles University, Czech Republic, and the Directorate Advisor on International Cooperation and Research Grants, Director of Supervisemin Limited. Welcome.
Okay.
Thank you very much, Dr. Chiara, for this very kind introduction. I would like to personally thank Professor Hatem Al-Gamal, the president of the conference, for his kind invitation, as well as the whole of the ASOGIC board. Obviously, it's always a pleasure to be back to the roots and the origins, Ain Shams University, where I graduated and did my training. This talk is about pop-up, and pop-up in this context means pelvic organ prolapse with uterine preservation. It's always a dilemma when we see patients with prolapse. The morning has been dedicated to reproduction and childbirth, so I'm taking you a few years after that, when women at many times suffer with organ prolapse. So what is the prevalence of POP? If we have a cohort of 100 women and we follow them throughout their lifetime, about 30% of them will have a pelvic organ prolapse. However, only 3 out of these 30 women will have a prolapse that is that significant that requires surgery. And out of these 3 women, 2 of them, or a little bit more than that, will have an apical prolapse. So most of the prolapses that are significant, that are symptomatic, that require treatment, are apical pelvic organ prolapse. And of course, we can have conservative management and surgical management if we're giving a lecture here to medical students, but we all know that when it comes to significant apical prolapse, the conservative management is probably not going to work. And it's the surgical option that is valid. There are different surgical options available to us. One of them now is not available in Europe and most of the world, which is transvaginal mesh, because there was an FDA ban in 2019, and it's not used since then. But the most effective procedures are the sacrocolpopexies, whether it's a traditional open abdominal procedure or endoscopic, laparoscopic, or now robotic. These are definitely by far more effective. However, there have been also some evidence. Of course, the best people we thought to ask are female gynecologists who are working in different parts of Europe, and we asked them if, when they grow older, God forbid, if they have a prolapse, what procedure would they want to be done for them? And not surprisingly, the majority chose sacrocolpopexy. So this is what the gynecologists who are working themselves believe is actually the most effective. But people always worry about that it's quite a big intervention, it might carry some risks. Of course, sacrocolpopexies in Europe are done by specialists in the field, urogynecologists. But is it really a very risky procedure? And we looked at this cohort from within our group, and we compared women who are considered to be high risk and those considered to be low risk from a surgical and anesthetic point of view, using the American Society of Anesthesiologists physical status scoring. And when you look at the perioperative outcomes, they were very comparable, the same whether the woman is high risk or not. And of course, the majority of women coming for POP surgery are an older group of women. And when you also look at the clinical outcomes for prolapse up to 12 months follow-up, they were very comparable. So actually these high-risk patients that we always talk about before we take patients to theater, sometimes is mainly in our mind and is actually an anesthetic problem, but from a surgical point of view, it might not be. We also looked at the outcomes by obesity. Obesity is a huge global problem for the person, but problem for us as carers for that person. It increases the risk, their complication rate, makes life difficult for us. But when you looked at outcome of sacrocolpopexies by body mass index, again, there was no difference whatsoever between the different groups when they were classified by BMI. So my first conclusion for this morning is that the majority of POP is actually an apical one. A sacrocolpopexy is considered now the gold standard. It's feasible to do it in patients who are considered to be high risk and those who are obese. Moving on to another important question when it comes to the decision-making process. What would you do for a woman who's presenting with a significant pelvic organ prolapse and she has a uterus? The options are, if you don't want to go into the sacrocolpopexy route, you're going to do a vaginal procedure with or without vaginal hysterectomy. If you're going to go down the sacrocolpopexy route, you can either do a sacrohysteropexy, you can do a subtotal hysterectomy and a sacrocervicopexy, or a sacrocolpopexy after a total hysterectomy. And of course, patients will always say, what do you think, doctor? Which is better for me? Interestingly, when you ask women, if you give them the possibility that the outcome is the same, of course, the relationship between a woman and her uterus varies from one woman to the other. And of course, we also believe it varies from one culture to the other. But interestingly, most of these studies that are reporting from the West. And interestingly, 6 out of 10 women in the USA, they would rather preserve their uterus when they're going for pelvic organ prolapse. A third of Hispanics, nearly 50% of Dutch women, and 40 to 60% of women in Austria, Germany, and Russia. Of course, we didn't survey everybody, and these are not my studies in the first place, but these are reports from these countries. So a significant number of women would rather, actually, if you tell them the outcome will still be good, they would rather keep their uterus. Why? I don't know, but we don't have to find the reason for that. So when it comes to pelvic organ prolapse and uterine preservation, all the urogynecologists know that the uterus is a passive structure in the mechanism of POP. Everybody is going to tell you this. Many, many years ago, people believed the uterus dragged everything down, but now people know it's not the case. So again, when we surveyed the female gynecologists, asking them about what procedure, when we asked them what would they do, would they have their uterus in or out? Funnily enough, most of these gynecologists, female gynecologists, said they want their uterus out, which is different to what women who are not gynecologists or doctors in the first place want. Of course, these female gynecologists are very important because they're the ones who are going to counsel patients later on in the future themselves. One of the arguments they proposed in their survey is that it would reduce the risk of me developing cancer later on in life. So this study was focused on exploring this hypothesis. Endometrial cancer is the third most common in malignancy in gynecology. 1 in 30 women, roughly, is going to develop a uterine body cancer throughout her life, and 1 in 159. But the risk of breast cancer is 1 to 8, from 1 to 8 to 1 to 12 women. It's so common. Colorectal cancer, 1 in 25 of people, whether men or women, will develop that. So it's a significant number. If we think we're going to start removing uteruses for a risk of 1 in 30 or 1 in 159, then we might as well start removing colons and breasts for everybody who reaches a certain age. But the other important thing is when we looked in this study, so in this study there are women who are having pelvic organ prolapse and they opted to have a hysterectomy. They did not have any problems, any high risk for any malignancy, and these specimens were all sent for histopathological examination. Also, before they had the surgery, they had an ultrasound scan to check for uterine pathology, anything suspicious or whatever. But they were going to have a hysterectomy anyway. And interestingly, when we looked at this cohort of patients, nearly 300 patients, the risk of unexpected malignancy, the prevalence of that was 1.7%. So it is there, but is this high enough or not? Well, let's explore that. And these were the different things. Some of them were actual cancers and others were precancerous conditions. We still actually included them. When we looked at the ultrasound scan that was done by a specialist beforehand, the ultrasound scan on these patients only picked up 1 out of the 5 patients who actually had a malignant or a pre-malignant condition. So the sensitivity of scan is 20%, the specificity is 88%. I have to confess that throughout my career as a medical student and as a trainee and as a consultant and now actually as a researcher, I really don't understand sensitivity and specificity. What's the meaning of that? Is this something good or bad? We like to see 90%, but we also like to see 90% in GCSE results and ثانوية عامة results. But what about sensitivity and specificity? That's why most of the people who look at diagnostic tests look at likelihood ratios, which again, the system is going to calculate it for you. So the likelihood ratio of a positive test is 1.72 and of a negative test is 0.91. Still, actually, it doesn't make any sense at all. I thought I understood sensitivity and specificity better when I look at this. But the likelihood ratio is a ratio that you use, and you use this nomogram, which you can use for any disease, and you plot your lines. And if we know that the prevalence of the condition before the test, the background risk for this patient, and you use the middle line here to gauge where you want to put your likelihood ratio based on the result, and you extrapolate the line, you'll know what is the actual risk for that patient. And if we apply ultrasound scan, and we knew that the prevalence was 1.7%, and you know the LR plus, now the woman's risk, if the scan is suspicious, is still less than 3%. So it did not add a lot of value. And a negative test does not also change matters for us very much. Therefore, my second conclusion is that the prevalence of a pre-malignant and malignant unexpected pathology in this cohort of women is about 1.7%, and the additional contribution of ultrasound scan to this cohort is very small. So if the patient is asymptomatic, and preferably if she's part of a national cervical screening program, then for you to save one woman from developing a precancerous condition, you need to do nearly 60 hysterectomies at the time of prolapse to stop one from getting cancer. Again, this is another number, and number means different things to different people, as we all know. So it's entirely up to you to decide whether it's worth removing all these uteruses by doing an additional procedure just to find this single woman or not. From an evidence-based point of view, it seems to be quite a heavy price to pay for identifying this patient. The last part of my talk, and it is related to the other reason why the female gynecologist still wanted the uterus to be removed, which is a fact, is that the risk of anterior wall recurrence, if you keep the uterus in and do a sacrocolpopexy, is higher than women who have a hysterectomy. And the reason why this happens is because when you are pulling the anterior vaginal wall and attaching it to the sacral promontory, which is what you do in a sacrocolpopexy, if you have removed the uterus and you are just hanging the cervix, or the cervix and the vagina, cervicopexy or a colpopexy, you are you're tenting the vagina up. You don't allow it, or you reduce the risk of it bulging again. However, if you're doing a hysteropexy, if you're keeping the uterus in, the anterior mesh will have to be hanged on the isthmus of the uterus. So the anterior wall of the vagina is left unsupported. And of course, most of the apical prolapse will have a concomitant anterior wall prolapse. That's why there is a high risk of recurrence, anterior wall recurrence, if you leave the uterus in. And if you think about a sacrocolpopexy, there are different variants, but the commonest variant is that you have a strip of mesh at the back of the uterus that is attached to the back wall of the vagina and the cervix and attached to the sacral promontory. And from the front, there is the anterior mesh, which is attached to the isthmus, and then you split it into a Y shape and get this through fenestrations in the broad ligament and back again to be attached to the sacral promontory. Within our unit, we have modified this slightly to address this issue of an recurrent anterior wall prolapse. So now the back mesh, as you can see, is not a strip. It also has two arms coming out. And we use the fenestration through which the anterior mesh was going back to actually take it from behind forward to attach it to the isthmus of the cervix. This means that the anterior mesh now is free to be attached to the anterior wall of the vagina and provide the same tenting and lifting the vagina properly. And these are only preliminary results, but the initial results of this modification have shown that we have reduced the risk of anterior wall recurrence significantly, from 17% to 2.7% in this cohort of women. So my third and last conclusion for this talk is, compared to standard LSH, the Pilsner modification, which I've been talking about, shows no significant difference between it and the standard technique when it comes to safety. However, there is a huge trend toward reducing anterior compartment failure. When you look at the mesh on ultrasound scan afterwards, it's very similar when it comes to placement compared to the traditional one. I was going to show you a video, but I have 11 seconds. This is the posterior mesh, and this is how it is placed behind the uterus. It will be fixed, and these are the two limbs that are passed through the fenestrations in the broad ligament, and they end up going around the cervical isthmus. This frees the place to put the anterior mesh in a lower place. Thank you very much.
Professor Khaled Mustafa Kamel, do you think that the preservation of the uterus would increase the possibility of the recurrence of relapse?
Would increase the possibility of recurrence? I don't think so. The evidence up to now, from what is published and also from our unit, is that it does increase the risk of anterior wall recurrence. I'm talking about preserving the uterus in the context of a sacrocolpopexy. So just doing a sacrohysteropexy compared to doing a subtotal with a cervicopexy or a total hysterectomy with a sacrocolpopexy. Because we use sacropexy as the mainstay procedure for the management of prolapse in our unit. So what I'm talking about is in relation to this. It does not increase the risk of recurrence. It increases the risk of anterior wall recurrence, and that's why this modification I talked about. I cannot comment on comparing a vaginal procedure with or without hysterectomy, because this is very rarely used in our unit.
Then if there is any comparison between the preservation of the cervix rather than preservation of the uterus?
If you do a subtotal hysterectomy and preserve the cervix, this has lots of benefits. It has the benefits of both worlds. It makes the hysterectomy much less complex and much quicker, with less blood loss and less operative time. All are very important, of course, in a busy unit. And for the patient, undoubtedly, but it also gives the benefit of being able, within a sacrocervicopexy, to be able to pull the vaginal wall in a much better angle compared to a hysteropexy.
Would you prefer that this sacral cervicopexy is best than the colpopexy in decreasing the incidence of mesh erosion?
I'm sorry, Mohammed, the sound is not very good. Can you say this again?
Would the cervicopexy, circular cervicopexy, better than the sacral colpopexy in decreasing the incidence of mesh erosion?
For a cervicopexy compared to hysterectomy?
To decrease.
Yes, it reduces the risk of mesh extrusion into the vagina. If you leave the cervix behind, it makes it a quicker procedure. Certainly, it will be the preferred option if a woman decides to go for a hysterectomy, unless, of course, if there is a need for the hysterectomy. This is different. I mean, if the need is, fibroids or whatever, which is unlikely in this age group, then you can do a subtotal. But if you're suspecting or worried about cancer risk, then you need to remove the cervix.
What about your comparison with pectopexy?
Pectopexy.
Yeah.
We are starting within the unit to do work on this. It's just much quicker and obviously than sacropexy, but we don't have long-term data yet on that.
Okay, thanks.
Thank you very much.
Thank you for that. Our main issue as women is stress incontinence. Have you done any longitudinal studies that really look at the incontinence after this procedure amongst these women?
Thank you very much. I mean, all the papers we have talked about, we always actually, as part of our questionnaires, we assess both clinical outcomes. So we always use POPQ, for example, as an objective way of assessing the degree of descent or any failure in any of the compartment. And we we collect always a lot of patient-reported outcomes, satisfaction, sexual questionnaires, and also questionnaires about incontinence. So all the results we have are from the patient's perspective. We don't necessarily do objective follow-up tests for that. When it comes to stress incontinence, of course, some women actually might still continue to have this, but certainly with the sacrocolpopexy, the risk of this recurring is much lower. But sometimes you might, if we know that the woman has stress incontinence from before, we might need to do an additional procedure like a TVT or whatever. And at many times we also warn the patients that they might have this stress incontinence de novo afterwards, and we would not know about this until the procedure is done. So they might have to come back for a TVT. But TVT is a fairly minor day procedure. It's not a problem. The other thing we are really doing a lot of work on within the department is in relation to preventing the pelvic floor disorders in the first place. We had a workshop in this conference, and we do a lot of work actually with the WHO in relation to this, in reducing the risk of pelvic floor disorders in the first place, because once this happens, whatever treatment will never be as good as things beforehand.
Any questions for the previous lectures? Professor Khaled, I have one more question. Is there any benefit of the laparoscopic sacral cervicopexy or hysteropexy in decreasing the paravaginal or treatment of paravaginal defect? Would we need to have extra stitches for paravaginal defect, or rather the sacral cervical or hysteropexy would do the two functions?
We don't do any additional procedure for a paravaginal defect when it comes to sacrocolpopexy, because the support provided is really quite strong and efficient on its own. But if we are doing a vaginal procedure, we do paravaginal repairs. And there is a procedure actually that we do within our unit where we try to do some form of paravaginal correction. But it's still early days as to whether you get good long-term outcomes or not compared to not doing anything.
Okay, thanks, sir. احنا في انتظار الاستاذ هتسال انا.
Now my question to Dr. Ann Beatrice. I have noticed in your presentation that most of it comes from data. And I would like to ask you, as a president of the FIGO and the African Federation of OBS and Gynae, how do you find the Egyptian data? Do you usually find a clear, proper data about maternal morbidities, maternal mortalities? Because I've seen in many graphs that Egypt is not there. So would you please let me know?
Thank you very much for that question. I actually belabored looking at data, and yes, Egypt is there when you actually come to the SDG country profiling. But the demographic data, it seemed to have a gap for me because I depended very heavily on the WHO and the UNICEF data. So data from the MENA region, I think, is an area that we really also need to have a look at, generally. Yes.
Thank you very much, and it's our pleasure to be here.
Many questions had been asked for Dr. Amr Assam, and he will conclude his lecture.
I think it never happened before, yeah. Okay. Dr. Ann. ثانية واحدة. Okay, we in the session 15 minutes ago, we finished the exchange, the blood transfusion, or the effective replacement. We finished all this. I think it never happened before that someone took 2 sessions like this. Okay, now the most important is the interventions. Dr. Ann Piatras is from Kenya, and I lived in Kenya many years, and I've worked in different rural places. So our problem is the decisions. Like for here, when you look at the Royal College guidelines, you will find that pharmacological measures, if fail to control hemorrhage, surgical interventions should be initiated sooner rather than later. I'm very happy with this. What is sooner? This is when. So this is not a decision. This is information. And then intrauterine balloon tamponade is an appropriate first surgical intervention for most women when uterine artery is This takes a lot of hype. Balloon tamponade actually, when tried, it resulted in many deaths. But we don't care about this because we don't have balloon tamponades from the start. In our facilities, we don't have Becker's balloon. We use uterovaginal pack, so we have to modify this. And then conservative surgical interventions may be attempted as second line, depending on clinical circumstances. What are these circumstances? Again, more information and less decisions. And then resort to hysterectomy sooner rather than later. When is sooner? So, with our physicians leaning their back on the RCOG guidelines, they need more decision-based guidelines. I will skip this. Now, in uterine balloon tamponade, look at this sentence, please. Balloon tamponade, when employed successfully, avoiding hysterectomy in 91% of women. Not successfully arresting bleeding. Successfully avoiding hysterectomy. The mindset of the physician who reads this is what? Is that avoiding hysterectomy is a success. He's very happy. He delayed hysterectomy till the patient died because in his mindset, hysterectomy is a failure. So we needed to change this. All of this is evidence-based information. And even in the MB Brace report in October 2023, they advised the Royal College and NICE committee to put more restrictions on tamponade, when to use them, when to not use them. And the FIGO the same. The FIGO, they think that very weak recommendation, very low quality of evidence to use balloon tamponades. This is not my issue. My issue is that when they move on to hemostatic sutures, you will find a lot of information, no decisions. When to use them, when not to use them, there is no decisions. But there is Bardo one sentence which struck us. Failure rate of sutures leading to hysterectomy was 25%. Again, they stress on the point that hysterectomy is a failure. Success is not doing hysterectomy, and this is wrong. We need to change this mindset because hysterectomy is the definitive treatment. All of the guidelines, they are just evidence-based, valuable information. Valuable for education, valuable for patient counseling, but not valuable in management. Okay, like when internal arterial ligation is being considered, when shall you consider it? It's not written. Selective arterial occlusion, we don't have it. And then we come to hysterectomy. Hysterectomy is the last choice. Even in the guidelines, in the way it is written, it's the 5th choice. لا بعد. I still have 15 minutes. طيب, okay, thank you. Anyway, I made my point clear. What we did is, sorry, I'll just take 1 minute. What we did is that we made posters and we distributed them all over Egypt. Posters with clear pathway for our physicians. Okay? So we thank you very much.
Thank you, Dr. Amr Assam, for this elegant lecture. And our next speaker is Professor Dr. Amr Al-Husseini, the head of Obstetric and Gynecology Department at Ain Shams University. The title is Postnatal Venous Thromboembolism Prophylaxis, sponsored by Sanofi Pharmaceuticals.
Good morning. Thank you very much for the organizing committee and my dear friend, Professor Dr. Hatem Al-Gamal, for the amazing organization. And it's very important to notice that this conference has been awarded 64 CME hours by the European regulators. This is unprecedented in any conference in the world. And these people, when they give us this accreditation, it means that we are doing something correct. Here, I'm doing this presentation as a part of the business and the sort of cooperation between our department, our university, and the market with Sanofi. And it's a very important cooperation between the companies and any conference, because they are the one who help to fund our conferences. Thrombosis in pregnancy is very important to notice that 1 or 2 people will have thrombosis during pregnancy. The antenatal period, there is a 5-fold increase in the incidence of DVT, while in the postnatal interval, it's up to 20-fold increase. So it's one of the leading causes of pregnancy-related death in the developed world. We have one of the highest cesarean section rates in the world, if not the highest. And the data shows this. The incidence of C-section in Port Said is about 91%. In Kafr al-Sheikh, it's about 88%. In Gharbiya, it's about 84%. And in Matruh, it's 39%. Why? Because people there are still living a very simple life. They don't see doctors very frequently, so they escaped from our hands. So they are still having normal vaginal deliveries. The causes of maternal death in the UK, the leading causes are cardiac disease, neurological causes, sepsis, and thrombosis, and thromboembolism comes at the 4th place. And this was the same between 2018 and 2020. There was a decrease in the incidence of maternal mortality related to sepsis and hemorrhage, but there was an increase in the cases related to thromboembolism. The RCOG, the Royal College of Obstetricians and Gynecologists, had done its effort to reduce the risk of VTE during pregnancy and puerperium, and there was a Green Top Guidelines number 37A released in 2015 and reviewed in 2023, having a scoring system for the risk of VTE. And each of these factors will be given a specific score. For instance, if there is a previous history of VTE provoked by major surgery, it will give 4 points. If there is a known high risk possibility of thrombophilia, will be given 3 points, and so forth. If the total score is more than 4, Antenatally, we have to consider thromboprophylaxis from the first trimester. If the total score is 3, antenatally, we have to consider thromboprophylaxis from 28 weeks. If it's equal or more than 2, postnatally, we have to consider thromboprophylaxis for at least 10 days. If admitted to the hospital antenatally, we have to consider thromboprophylaxis. If there is a prolonged admission, more than 3 days, or readmission to the hospital, then we have to consider thromboprophylaxis. Then we have to choose, while reducing the risk of the venous thromboembolism during pregnancy and puerperium, between the unfractionated heparin and the low molecular weight heparin. We all know that the main advantage of the low molecular weight heparin is that it doesn't need monitoring. It's given less frequently, usually once per day. And it's very important to notice that there is less impact on the number of platelets. While the unfractionated heparin, its half-life is shorter, it can cause more bleeding, it can cause more thrombocytopenia, and it needs to be given twice per day. But the main advantage of the unfractionated heparin is the cost. And if we are going to use unfractionated heparin, we have to use a prophylactic dose of 5,000 international units given subcutaneously twice per day, every 12 hours. So what's the magnitude of risk of VTE after cesarean section? We have to say that the magnitude is very high if it's an emergency cesarean section, while the risk is much less if it's an elective cesarean section. And here we have a postnatal assessment and management to be assessed on delivery suite. If we have a high risk factors like any previous VTE, anyone requiring antenatal low molecular weight heparin, high risk thrombophilia and low risk thrombophilia. In this case, we consider this a high risk. So it's a long table. I will not bore you by reading every bit of it, but it's again a guide how to classify the risk of the patient, whether she is a high risk, intermediate risk, or low risk. And what dose shall we use in our patients? Unfortunately, I see too many patients receiving 20 milligram daily while their weight is like 100 kilograms. So the dose is according to the weight. Most of the patients will need around 40 milligram daily because most of the patients will lie in the area between 50 to 90 kilograms. And here is a quick case. A 20-year-old female attends to the hospital for elective C-section. She's gravida 1 para 0, preterm labor, did not need VTE prophylaxis after making the assessment for her, and her weight is 75 kilograms. What about postnatal VTE prophylaxis? We have to go back to the table we had. It's an elective C-section, but it's a preterm labor, so there is one risk factor here. Two risk factors. What about postnatal VTE? 10 days postnatal prophylaxis, because she has two risk factors, and which dose she will need. If we go back, her weight is around 75, so she's in the area between 50 and 90, so 40 milligram dose of low molecular weight heparin. Thank you very much. This is a presentation about our hospital, I would like to give briefly, just to give you an idea and a glimpse, what's Ain Shams University Maternity Hospital. Our hospital is mainly a free hospital, and it's a story of success. If we go back to the history, the hospital was founded in 1950. The gynecology service started the duty of teaching the science of obstetrics and gynecology according to international standards and serving many Egyptian women. The beginning of the hospital, we had 140 beds divided among 4 units, and in 1986, at the era of the late Professor Rojdi Ammar, the current separate building was opened, which holds 476 beds. We have 476 beds among 6 general units. We have a massive range of deliveries, up to 20,000 deliveries annually. We have an obstetric ICU unit with 16 beds, fully equipped, plus 3 dialysis machines. We have a neonatal ICU. We have outpatient clinic. We have 6 subspecialty units. We have our own blood bank, and we have our own radio diagnosis unit. In the past 5 years, we started to restore the maternity hospital infrastructure and setting up of a new electricity grid, firefighting system, and gas station, because we could not do any innovations without restoring these very important services. We have to thank Professor Ahmed Rami, the previous head of the department, and Professor Rihab Abdurrahman for the efforts they done to innovate these infrastructures. And we also innovated the maternity hospital emergency room. This was the era also of Professor Ahmed Rami. And yesterday, only yesterday, we received the first auditorium for undergraduate and postgraduate education. One of the 9 theaters for educations that we have, and this is the first one that we started and we opened yesterday. It's amazing. And also, we had a new state-of-the-art minimal access surgery unit. This was a project that took around 3 years. We have now 4 endoscopy towers with the state-of-the-art modular systems. And this is how it looks. It's connected with the hospital information system. And also we have a fully equipped training center that was donated to the hospital with 2 telepacks and a fully equipped training center connected to the theaters audiovisually. This was a donation from Karl Storz, Germany. And we recently also started the robotic service in Ain Shams Specialized Hospital. We have 3 professors now operating on the robot. And it's very important to notice that the largest number of patients operated on the robot are by the gynecology department. We also innovated the early cancer detection, which is one of our big pride, because this unit has been there for 40 years and founded by our great late professor, Professor Muhammad Bayoumi Sammour. And this unit has a dedicated gynae pathology unit. Also, we innovated the fetal medicine unit, and we have signed a memorandum of understanding with the University of Leuven, and we are about to start a fetal surgery center in cooperation with eminent consultants and professors from Chicago University, from Leuven University, and from Spain. And we also started to offer multi-subspecialty diploma in different fields of obstetric and gynecology, in assisted reproduction, in gyneurology, in minimal access surgery, and in fetal medicine. We have a waiting list for each specialty, at least 500 candidates, and we accept only 20 candidates per year. Also, we are in the making of a high dependency unit that will have 6 beds. And hopefully, I would just, with the president of our university, Professor Muhammad Zain Al-Abidin, that we are about to open our neonatal ICU, which will be maybe the second largest in the world, with 76 neonatal ICU beds and ventilators. Also, we are innovating the urogynecology unit, and we are also planning to improve and modernize our inpatient ward. We are planning to have ensuite rooms for every 2 or 3 patients, with a private lavatory and private wardrobe, fully air conditioned, is going to be one of the best in this country. Also, we are starting to transform the second phase of our gynecology theaters. We have in total 9 gynecology theaters. We innovated 3. We already in the process of innovating the other 6 theaters. We already had the fund and the equipment, and we are about to start within the coming couple of weeks. We have a strict 5 years plan after approval of the department council and the approval of the dean of the college and the approval of the chief executive officer of the hospitals. The plan has been put for the upcoming development projects for future of this department. Thank you very much.